Hello, I'm Dr. Kate Allen. I'm a former paediatric trainee who changed career path to general practice, and I'm currently a GP registrar in the Chesterfield scheme. Having come from paediatric to general practice, I've developed a whole new appreciation for the challenges GPs face when seeing patients early on in their journey, and particularly with young babies when they have a vast spectrum of normal and the challenges identifying when things aren't. The clinical case I decided to focus on is of a baby all GPs will have had experience of seeing. GPs will commonly be the first point of contact for parents when they are concerned about their baby. With my article, I want to try and help GPs with the skills to ascertain whether this is normal baby development and behaviour, or if this is indeed a cow's milk protein allergy. There is a diagnostic process that can make it more straightforward for GPs to be able to do this. This is a challenge for paediatricians and GPs, particularly with heightened parental awareness and media attention around the subject. So the clinical case we are going to focus on today is a mum brings her 4-month-old baby boy to see you. She has seen several GPs over the past few weeks with concerns about nappy rash, eczema, and loose stool. She feels her baby cries a lot more than other babies and is often unsettled when feeding. She is a first-time mum. Her baby was born at term with a normal delivery, and there are no antenatal concerns. Mum breastfed for the first few weeks and is now formula feeding. He is otherwise growing and developing normally and up to date with his immunisations. There is no significant family history. We explore Mum's concerns, and she's been doing some reading about cow's milk protein allergy and is wondering if this could explain her baby's symptoms. So again, the case I'm sure we're all very familiar with. So cow's milk protein allergy is the most common food allergy and can affect 2 to 3% of infants. But the true prevalence of cow's milk protein allergy is quite controversial due to different methods used. Studies have shown an increase in the incidence and prevalence of allergic diseases over the last decade, and it's likely due to complex environmental, lifestyle and dietary changes. There's also a change in parental perception of what is normal for a baby. Cow's milk protein allergy in exclusively breastfed babies is rare, but almost always reported to be in the range of 0.4 to 0.5%, but there are figures reported to be as high as 2.1%, which also suggests there's an overdiagnosis in the breastfed infant. So we're going to talk about two main types of cow's milk protein allergy, which as GPs and GP registrars we do need to be aware of. The two main different types do change in how we manage and follow up these babies. The most common type of cow's milk protein allergy we will see in general population is non-IgE mediated cow's milk protein allergy. However, there is a different type of cow's milk protein allergy we do still need to be aware of, and this is IgE-mediated allergy, as this presentation will differ, and the diagnosis and treatment for these babies will be different. IgE-mediated allergy will have an onset of symptoms within minutes following ingestion, and symptoms can be severe, such as anaphylactic reaction, and babies can have immediate vomiting, regurgitation, or immediate diarrhoea. Infants can also have wheeze, breathlessness, urticaria, and angioedema. Differences as well that IgE-mediated allergies can be confirmed in allergy testing and are often positive in skin prick or IgE testing, and children should therefore be referred to allergy clinic for assessment. 58% of babies with an IgE allergy will have a reaction within 2 hours, but there are still 42% will have a slightly later reaction, typically with atopic dermatitis or symptoms affecting the GI tract. Infants with early reactions are more likely to be picked up on skin prick testing or IgE testing than those who have later reactions. And then secondly, the most common one we need to be aware of is non-IgE mediated allergy. Those differs because symptoms will be more delayed. They can happen after 2 hours of ingestion of milk products, but symptoms can occur anywhere between 6 and 72 hours after having milk products. The symptoms are broad and non-specific and can affect the skin, GI and respiratory systems. There can also be a family history of allergy. There can be involvement of several different organ systems, and there can be a lack of improvement with other therapeutic measures that a GP might have tried beforehand. Evidence suggests that the majority of infants that we see will have mild to moderate symptoms, and the challenge that we face is there is no diagnostic tool to help us diagnose an IgE-mediated allergy, and the non-specific clinical presentations means there's both an overdiagnosis in general practice, but also an underdiagnosis in general practice. So I'm mostly going to focus the article now on symptoms relating to non-IgE-mediated allergy, and we'll go through some of these in more detail. So research has shown that children with cow's milk protein allergy have symptoms in at least 2 of the following organ systems. So we've got the GI tract to begin with, and 50 to 60% of babies will have symptoms in the GI system. with frequent regurgitation, vomiting, diarrhoea, constipation, and they can even have blood in their poo. 50 to 60% of infants will have skin reactions with eczema or angioedema, and 20 to 30% of infants will have respiratory symptoms such as a runny nose, cough, or be wheezy. And another common symptoms that babies will have is have colic or infant distress. Symptoms often, but do not always, occur within the first few weeks after introduction of cow's milk into the diet. So cow's milk protein allergy is easily missed in primary care and needs to be considered as a cause of babies being more distressed, but also of a diverse range of different clinical symptoms. However, symptoms of non-IgE cow's milk protein allergy do have an extensive overlap with many other clinical symptoms that present in babies. Diagnosis should be considered when symptoms are multiple, significant, persistent, and resistant to other forms of medical treatment. I wanted to highlight a few common baby symptoms that GPs will be presented with, and when we need to think about this being a potential sign of cow's milk protein allergy. One of these is colic. So many parents will visit their GP with concerns that a baby is crying excessively. Crying and irritability can affect 20% of infants, but cow's milk protein allergy is rarely a cause. Colic is a common condition frequently diagnosed by GPs. The pathogenesis of colic is quite unclear, and is likely to be caused by a number of behavioural, psychological and organic factors, such as allergy, food hypersensitivity and gut dysmotility. Infantile colic can overlap with cow's milk protein allergy, but the incorrect recommendation of anti-colic remedies can also at the same time delay diagnoses. When we have babies that present with frequent regurgitation or even gastroesophageal reflux disease, again, regurgitation is a very common condition of infancy, and parents will often present to their healthcare professional with concerns that their baby regurgitates, vomits, and has reflux symptoms. Gastroesophageal reflux disease in infancy is much less common than regurgitation, and can also be considered a normal baby symptom, and cow's milk protein allergy is often unlikely to be responsible. But there is, however, massive overlap between babies who have proven gastroesophageal reflux disease and cow's milk protein allergy, and 15 to 21% of infants tend to suffer from both conditions. Current advice would be to trial a diagnosis of cow's milk protein allergy before we then start on treatments for gastroesophageal reflux disease. Then we've got constipation, again, an incredibly common symptom of childhood, and the vast majority of cases have a functional etiology. Non-IgE cow's milk protein allergy is only rarely a cause of constipation, but should still be considered in children who have constipation that's unresponsive to the standard medical treatment. Eczema can again have strong association with cow's milk protein allergy, and it often associated with babies who are younger and have quite severe eczema that is difficult to treat and can also be considered as a potential diagnosis. Then as GPs, we do also need to be aware of lots of other differential diagnoses that present to us with babies. We need to be thinking about metabolic disorders. We need to be thinking about anatomical disorders, celiac disease, cystic fibrosis, other allergies to foods, infection, sepsis. And if we've got any doubt, we do need to be referring babies on to paediatrics for a further assessment. So coming now to making an assessment of our babies, when we're making a diagnosis of cow's milk protein allergy, we need to start with an allergy-focused history, and we need to do a full physical examination of the babies. It's important to gather information about the baby's feeding history and sources of cow's milk protein. We need to gather details with respect to growth, development, and also presenting symptoms and signs that may indicate cow's milk protein allergy. It is also important to inquire about personal and family history of allergic disorders and atopy, such as asthma, eczema, and hay fever. Having a sibling with an allergic disorder has reported to double a patient's risk of allergic disease. In non-IgE mediated cow's milk protein allergy, symptoms of slower onset and non-specific, and we have no diagnostic test. Therefore, diagnosis can only be made by a trial of dietary exclusion, and then we need to follow this up with a reintroduction of cow's milk protein. This is the gold standard, and this helps us to diagnose mild to moderate cow's milk protein allergy in formula-fed infants, and should be mandatory in the workup of infants with cow's milk protein allergy. The only exception we should have is patients that present with life-threatening symptoms such as anaphylaxis, or if they've been found to have high levels of IgE on allergy testing. So the diagnostic elimination diet should typically last at least 2 weeks. It can be up to 4 weeks if a baby has eczema or other GI symptoms. If the child is formula-fed, elimination diet should start with a therapeutic formula for cow's milk protein. The first choice should be an extensive hydrolyzed formula, as per your local prescribing guidelines. In some situations, however, we do need to think about maybe putting the baby straight on to an amino acid formula. We should think about this in cases of severe allergy, if there are lots of other multiple food allergies, or any specific GI symptoms that we are concerned about. However, if baby symptoms don't disappear with an amino acid formula, the diagnosis therefore is quite unlikely. We probably do need to be referring these children on for further assessment. If we do find that we started an alternative formula and our symptoms do substantially improve or disappear after 2 to 4 weeks, then we need to do a challenge of a formula-based cow's milk protein. We need to do an oral challenge to start with a very small dose of 1 ml of milk product and increase stepwise to significant volume of at least 100 ml. IMAP guidelines are really useful resources for GPs and parents and give lots of parental information how they go about reintroducing cow's milk protein to their baby. It gives a gradual stepwise process of 30 ml a day, which can be given over 7 days, starting with the first bottle of the day. If we have no reaction after 7 days, then all babies' bottles can be cow's milk. Cow's milk should be continued at home every day with at least 200 ml a day for 2 weeks. However, if symptoms do come back with cow's milk protein allergy, then we can suspect this is the diagnosis and can confirm it. And the child should be on an elimination diet then for 9 to 12 months of age, or for at least 6 months. If you do not develop symptoms on the cow's milk and up to 1 week after being on cow's milk, then the diagnosis of cow's milk protein allergy is excluded and we can resume a normal diet for the children. Formula-fed infants with severe cow's milk protein allergy should refer to paediatrics and start on an elimination diet, preferably with an amino acid formula. Then going on to the breastfed baby, cow's milk protein allergy. So cow's milk protein allergy in the breastfed baby is rare compared to formula-fed infants, and only about 0.5% of exclusively breastfed infants have any clinical reaction to cow's milk protein, and most symptoms are mild to moderate. The level of cow's milk protein in breast milk is 100,000 times lower than that in cow's milk. Therefore, dietary restrictions to the breastfeeding mother aren't usually necessary. Management principles, however, differ compared to the formula-fed infant. And if we're suspecting cow's milk protein allergy, we need to reduce the infant's exposure to cow's milk protein in mum's breast milk by asking mum to stop the consumption of any cow's milk protein containing products. It is recommended that exclusive or partial breastfeeding is continued as before unless there are any alarming symptoms. Mum should avoid cow's milk protein for a minimum of 2 weeks, but can consider up to 4 weeks in cases of eczema or allergic colitis. If we have no improvement in symptoms, mum should resume her normal diet and a referral to a paediatric specialist to investigate an alternative diagnosis. However, if symptoms improve or disappear, 1 food per week can be reintroduced into mum's diet, and if symptoms do not reappear, the elimination can be stopped. So I'm going to talk a bit about overdiagnosis of cow's milk protein allergy, because there's extensive links between the formula industry, and this has raised the question over this being an industry-driven diagnosis and whether increased prescriptions are a true reflection of an increase in prevalence. Most breastfeeding mothers will have researched symptoms online, and top hits on Google are often industry-funded sites relating to cow's milk protein allergy. And most mothers will have already excluded dairy from their baby's diet before consulting with a doctor. Healthcare practitioners are therefore encouraged that we do follow dedicated guidance and apply a short-term diagnostic elimination diet followed by reintroduction before we embark on a long-term cow's milk protein elimination diet. It is important we get the diagnosis right, because it does have nutritional implications for the baby. Specialist formulas do have a large number of free sugars, and the baby will get additional calories and predispose them to weight gain and obesity. Specialist formulas also do have a different taste and have a long-term impact on the child's taste preferences. And having a cow's milk allergy does add parental and family stress, with daily food allergy management and limited treatment options impacting family relationships and impacting social activities. However, if a diagnosis has been confirmed, then child should remain on a cow's milk-free diet until 9 to 12 months of age, or for at least 6 months, and then milk products can then be reintroduced. And this is well known as the milk ladder. And this builds on the concept that the more baked a milk product is, the less allergenic it is. If a child develops a reaction to any of the steps, they are advised to go back to the step before and continue eating foods from that step and the steps preceding it. There are 6 steps on the ladder, building all the way up to pasteurised milk or more normal infant formula. As a GP and GP registrar, we do need to also consider whether we need to refer families to a paediatric dietitian. This is important to monitor growth, nutrition, but also to give advice about hypoallergenic infant formulas. And similarly, for breastfed mums, should be still referred to paediatric dietitians so they can give advice about maternal diets and any additional vitamin supplements that mum might need. So I'm just going to highlight some of the key points for what we've talked about today. So we've got two main types of cow's milk protein allergy, IgE and non-IgE. Infants with suspected IgE allergy should be on a cow's milk-free formula and referred to paediatrics for further testing. The symptoms of non-IgE cow's milk protein allergy are wide, broad, and the very same symptoms can occur in normal babies, which poses a diagnostic challenge for GPs. It is important after 2 weeks to 4 weeks of having a cow's milk-free diet that an oral challenge of cow's milk should be done to help confirm this is in fact the diagnosis. It will affect 2 to 3% of infants, however the true prevalence is controversial, with some concerns regarding the overdiagnosis of cow's milk protein allergy. Once we've confirmed the diagnosis, they should be on a cow's milk-free diet for at least 6 months before starting on the milk ladder, if being managed as mild to moderate IgE allergy. Thank you for listening.